Hello everyone, welcome to our module on anti-anginal drugs. So what happens in angina is either there is decreased oxygen supply or increased demand by the myocardium. To relieve angina, either we need to increase the oxygen supply or decrease the demand of the myocardium or both. So first class of drugs is nitrates. Nitrates are powerful venodilators and to some extent dilate coronary arteries. Drugs in this class are glycerol trinitrate, isosorbide dinitrate, and isosorbide mononitrate. Glycerol trinitrate is the shortest acting. Its onset of action is 2 minutes and it lasts for 20 minutes. Side effects include severe headache, postural hypertension, reflex tachycardia. Patient develop tolerance with continuous use for 12 to 16 hours. What happens is this glycerol trinitrate donates nitric oxide, which is a potent vasodilator. The enzyme which breaks down glycerol trinitrate into nitric oxide is sulfur containing enzyme and it gets saturated with continuous use for about 12 to 16 hours. Other drugs such as isosorbide dinitrate, its onset of action is 5 minutes and lasts for 30 minutes. Third drug isosorbide mononitrate, its onset of action is 15 minutes to 30 minutes and it lasts for 1 hour to 4 hours. Next class of drugs is beta blockers. Beta blockers include beta 1 and beta 1 plus 2 non-selective beta blockers. Beta 1 blockers are metoprolol, atenolol, acebutolol. These beta blockers decrease cardiac demand by reducing heart rate and cardiac contractility. Adverse effects of these drugs include rebound hypertension if discontinued abruptly, bradycardia, bronchoconstriction, fatigability, and exercise tolerance. Metoprolol is a preferred drug in diabetics. Beta blockers are used in combination with nitrates. Nitrates increase oxygen supply and beta blocker decrease demand. Beta 1 plus beta 2 blocker is propranolol, but side effects with these drugs are higher. Next class of drugs is calcium channel blockers. Calcium channel blockers block L-time calcium channels in vascular smooth muscle and in myocardium. These help by smooth muscle relaxation and vasodilation and reducing the work of the heart. Smooth muscle calcium channel blocker is nifedipine. Myocardial calcium channel blocker is verapamil, and diltiazem blocks both calcium channels of smooth muscles and myocardium. Calcium channel blockers are relatively safe drugs without side effects like other vasodilators. Nifedipine can be used with beta blockers, but verapamil and diltiazem never should be used with beta blockers. Side effects of calcium channel blockers include arrhythmia, sinus bradycardia, heart block, and reflex tachycardia. Next, additional drugs are potassium channel openers. These class of drugs include nicorandil. It is a very effective drug. It opens ATP sensitive calcium channels in vascular smooth muscles, causing their hyperpolarization. As a result, smooth muscles in vascular wall relax and it leads to vasodilation. Nicorandil can also act as nitric oxide donor, which is a powerful vasodilator. Next class of drug is fatty acid oxidation inhibitors. Myocardium usually tends to oxidize long chain fatty acid for ATP, but drugs like trimetazidine, it inhibits oxidation of long chain fatty acids and promote oxidation of glucose. This decreases O2 demand of the myocardium. The next classes of drugs are thrombolytics and antiplatelets. Thrombolytics are given in unstable angina to lyse the clot. These are used only in ST elevation MI because with thrombolytics there is a very high risk of GI bleeding and intracranial bleeding. So in ST elevation MI we need to protect the heart, so we don't care about the other side effects of thrombolytics. And thrombolytics are to be given within 4 hours of the initiation of MI because after 4 hours their action is gone. Example of thrombolytics include altiplase. The next drug is antiplatelets. These are given prophylactically to avoid further clots. Example include aspirin, and clopidogrel is used in patients who are aspirin intolerant. Thank you very much.